So it's now a pleasure to introduce Lauren Stiles, who is going to quantify the POTS patient experience and give the president of Dysautonomia's impression on the disease.
Thank you. I'm going to sit because we don't need a demonstration of what POTS can do when you stay upright a little bit too long and you're feeling woozy. So I think what you might have all picked up on, something that I picked up on listening to the prior lectures, is there's this underlying theme of we need more research on all of this. And that's a major goal of Dysautonomia International, is to raise awareness and raise as much money for research as possible, and also to engage in research in ways that may not cost as much money. My stool is sliding down on me. This is kind of fun. It's like a ride. So later on, you'll hear from two patients and a caregiver who will give you sort of personalized stories. But what I wanted to do today is to sort of quantify what these patients go through as they're trying to get diagnosed and what happens after they're diagnosed. So I have a disclosure. Even though I'm just a patient, I'm not a doctor, I did finally get some consulting fees, and I'm kind of excited about it. So, but it's not relevant to this talk. Let's see. So here are some of the challenges that POTS patients face. They have a lot of comorbidities. They're frequently misdiagnosed. And the misdiagnosis is not just having the wrong diagnosis, it's not being treated for POTS when you're misdiagnosed. There's great difficulty in finding physicians who have expertise in this. There's a lot of misconceptions about POTS. I meet doctors who tell me they know about POTS, and then they'll tell me, well, you can't have that, you're too old, it's a teenage syndrome. And I'm like, okay. So there are a lot of misconceptions. And most of these patients, there are some of them here today, they're totally normal-looking people and often young, and there's a lot of misunderstanding that they must be fine because they look fine. So here's just, I tried to pull from previous literature as much as I could to try to explain some of these things. So this was a Mayo study from 2002, and they looked at disability scores in congestive heart failure and COPD and POTS. And surprisingly, the disability was kind of similar. Importantly, the psychological domains were similar amongst, in this particular study, the healthy controls, congestive heart failure, COPD, and POTS patients. This was from Vanderbilt in 2011. The quality of life of POTS patients was similar to what is seen in patients undergoing dialysis. Both their physical and mental health was similar. So this is a project, I'll have a couple slides from the Big POTS survey. I don't know, how many of you in this room participated in the survey? Yay! This is a survey that Dysautonomia International did in cooperation with Vanderbilt. And then Dr. Raj moved from Vanderbilt to Calgary, so we added University of Calgary to the project. And we believe it's the largest POTS study to date. It's an online survey, so there hasn't been any clinical verification yet. We haven't taken the patients from the survey and made sure they actually had POTS and they were properly evaluated. But we were trying to get a sense of what happens outside of the large academic centers. If you come here, you're getting a very thorough workup. We know you have POTS if you've been diagnosed. But there are a lot of people who never get a chance to go to a specialist. So we wanted to see what was going on in the larger patient population. This is one of my favorite slides from, this was just presented this week at the Heart Rhythm Society by Dr. Raj out in California. And the comorbidities list, it actually would go 3 slides down off the page. There's so many comorbidities, but some of them, the less common ones, I left off. So unfortunately, it's not displaying all of the features. I don't know why, because it did on my slides this morning. But a lot of the comorbidities were things that you might consider part of autonomic dysfunction, like migraines, irritable bowel syndrome, chronic fatigue, fibro, Raynaud's, inappropriate sinus tachycardia. You can't see it on here, but vasovagal syncope was on there. These are things that are autonomically related diagnoses. It's not too surprising to see that in POTS. But there were other things that are not necessarily causative, but might play a role in the pathology of POTS. We're not really sure yet. One of them being Ehlers-Danlos syndrome, which is a collagen disorder that is likely inherited, but we're not sure because we don't have an exact gene for the type seen in POTS is usually the hypermobility subtype, which doesn't have a specific gene identified yet. Sorry, I'm out of breath. 84% of POTS patients reported some kind of comorbidity, and most of them who reported one had multiple. So I kind of think of these patients, and myself included, because I'm a POTS patient, we're kind of a hot mess of comorbidity. and a lot of the comorbid diagnoses are things that may or may not be related. And as a patient, when you go to different doctors, you end up getting diagnosed with different things. I was diagnosed with vasovagal syncope by one doctor, POTS by another doctor, inappropriate sinus tachycardia by a third doctor, irritable bowel syndrome by the GI doctor, and it was completely overwhelming. Like, wow, I can't really have this many different diseases. This must be related somehow, because I never had this before, and now I have all this stuff going on. So it's pretty frustrating for the patients to get that many diagnostic labels. Importantly, in this particular survey of 3,300 patients, 16% of patients did report a confirmed autoimmune disease. None of them stood out individually as being like something that a lot of the patients had, but Hashimoto's, celiac, lupus, and Sjogren's were the top 4. So a lot of patients especially think that EDS-related POTS is like its own thing, and autoimmune POTS is its own thing. But what we found is that EDS POTS and autoimmune POTS are not really any different because slightly more of the EDS POTS patients reported autoimmunity than the non-EDS POTS patients did. We also, I wish we had all the topics on here, but some of the comorbidities are probably underdiagnosed or underreported by these patients. As you can see, small fiber neuropathy is just under 10%, about 8%. And we know from research by Dr. Gibbons and Dr. Freeman and Mayo and elsewhere that 30 to 50, depending on the study you look at, 30 to 50% of these patients have some kind of small fiber neuropathy. Either the patients don't know that, or they haven't been seen by a doctor who knows how to look for it, which is probably the answer. Or they just, maybe they have seen an expert, but they just haven't had that kind of workup. So you touched on this earlier, so I'm not going to spend too much time on it. But so POTS and autoimmunity is something that we are excited about not excited in a good way, but excited in terms of research because there are a lot of things about POTS that we really don't understand, and it's not very easy to treat. But there seems to be some subset of patients that have an autoimmune mechanism in their POTS. And we haven't figured it out completely, but there is ongoing research, and I think it's important for people to know that there's this research going on. We're not quite there yet on having solid answers, but here's just a few of the studies. And our organization has actually been involved we see some of the smaller cohort studies, like Vanderbilt in Oklahoma did this 14-patient study on the adrenergic receptor antibodies. And we thought, oh, that's kind of cool, but 14 patients isn't really enough to prove anything. So we invited them to our conference, and they collected, I think, probably about 120, 130 POTS patients, and then they went to Vanderbilt and had a Control-a-Palooza. So they invited all the college kids to come give control samples because the controls at our conference were mostly parents and spouses, so it wasn't age-sex matched at our conference. SUNY Buffalo is Dr. Blichstein. She just did a retrospective chart review and found that her patients had 20% had reported confirmed autoimmune disease, and about a third had various autoimmune markers with quite a few of them were not specific, not enough to be diagnosed with a specific autoimmune disease. Mayo did a small study on their autoimmune dysautonomia panel and some thyroid antibodies and found about a third of their 33 patients had some of these antibodies. And then they came to our conference and did a larger collection last year, and that's still in progress. And then separate, I put Dysautonomia International. It was actually myself, my local neurologist at a private practice, and some researchers at SUNY Buffalo, not Dr. Blichstein, some other folks. We looked at novel early Sjogren's antibodies in idiopathic dysautonomia patients who had reported either dry eyes or dry mouth. And none of these patients had the typical Sjogren's markers, but 41% of them had these early Sjogren's antibodies, which are not used as part of the formal Sjogren's criteria, but are sort of research-based antibodies. And in the study, there were actually 10 POTS patients, and 6 of them had these novel early Sjogren's antibodies. So we're hoping to expand upon this and do a POTS-specific larger study. And that's important to remember. These are patients who had reported either dry eyes or dry mouth. And in the past, Mayo had done a paper saying about 50% of POTS patients have some kind of secretory dysfunction. So we need, obviously, a POTS-specific larger study to look at this. UT Southwestern is Dr. Vernino, and he's taking a look at muscarinic antibodies in POTS. And hopefully, we will be collecting for this at our conference this year. We're trying to secure a research grant to do that. These are just the citations for the previous slide. So this is really important. Diagnostic delay is a really big problem for our patient community, and I think it causes serious consequences. I think you start not trusting the medical profession. It might make you open to quacky ideas because you haven't gotten any help with a traditional doctor. It costs you a lot of money to be misdiagnosed and get bounced around. You're suffering because you're not being treated properly. And I think it can also really, increase your risk of developing depression and anxiety and other kinds of problems because you're feeling so sick and no one is telling you what's wrong. So the average diagnostic delay in our Big Pot survey was 4 years and 2 months, which is surprisingly improved by 1 year and 9 months from a 2013 survey that Dysautonomia International did on just under 800 patients. So we've improved the diagnostic delay time in about 2 years. We've improved it by 1 year and 9 months. So we think that part of that is probably we're kind of reaching a critical mass where there are just more people being diagnosed, so more doctors are going to learn about it just because they have a patient that has it. But also, we think a good part of this is the patient community is really getting mobilized and getting out there and raising awareness in a really big way. Average number of doctors seen is 7. So how many of you who are doctors have seen a patient who comes to you with a giant packet of medical records and you kind of roll your eyes immediately like, oh God, this is not going to be a fun appointment, and these are POTS patients, at least some of them. 24% of these patients, had seen more than 10 physicians, and that would have been me. I was one of these survey respondents. I can't even tell you, probably like over 40 doctors before I was diagnosed with POTS. And I was, I had good insurance. I'm an educated person. I live in New York, so I was going to big hospitals in New York City, and I just wasn't getting any answers. So sometimes doctors get annoyed when we do the doctor bounce. We go from place to place to place. But sometimes patients have to do that to get some answers. So these are dopey things that doctors said to me. And I put Patient Blaming 101 because I'm wondering if they might actually teach a class on this in medical school because it was so common to be told these things. The very first doctor I saw told me I was just hungover. And I said, no, I haven't had anything to drink in 2 days, and I had 1 beer on New Year's Eve, but he was just assuming that was it. He offered me a turkey sandwich, which I did take. So maybe you weren't cut out to be a lawyer. Go home and enjoy a glass of red wine to relax. And red wine actually makes me feel a lot worse, so I had figured that out already on my own. And I thought it was funny that the first doctor, thought I was a drunk, and the second one was telling me to drink. So this is my personal favorite, and I know there are other women in the room who've been told similar dopey things. You're doing this because you're 31 and don't have babies yet, and you're just trying to get attention from your husband. Wow, I'm so glad that guy has a medical degree. So this was actually my primary care doctor's partner, and apparently he was kind of famous for having this type of attitude towards female patients. But I was bedridden at the time, and he's pretty lucky because if I wasn't, I might have punched him. But And then you're deconditioned because lawyers sit at their desks all day. That's me sitting at my desk all day. I was not deconditioned when I got sick. I was actually on a 7-day snowboarding trip, and I had a bad concussion while I was snowboarding. And I did become deconditioned over time of, taking, actually took about a year to get diagnosed with POTS and 2 years to find out that I ended up having Sjogren's syndrome. And so Dr. Freeman and Dr. Gibbons might think I don't have POTS. And to me, the name doesn't really matter. I have autonomic dysfunction and I have an autoimmune disease, and I'm fine to just leave it at that. But so yeah, I think it's important to emphasize that deconditioning can happen. And as patients, it's very frustrating when a doctor might tell you that this is the cause of your illness and you resist that. But I think you should think of it as a consequence of POTS and make sure you treat it, whatever was causing it. Okay, so before you were diagnosed with POTS, were you ever told by a doctor that your symptoms were due to the following? So not surprisingly, a lot of patients are diagnosed or misdiagnosed, depending on the patient, with anxiety. And the symptoms of POTS look exactly like the symptoms of anxiety: tachycardia, palpitations, sweating, shakiness, and, so as patients, you might get annoyed when you get this diagnosis, but really, this is a reasonable guess by your doctor. Stress from work, family, school, all in your head. I mean, if you think a patient has a psychological cause of their symptoms, all in your head is never really a good answer. Send them to a psychiatrist or a psychologist for a proper evaluation and an actual diagnosis. 83% of the patients were given at least one psych label. So that's a very small percentage were not. And so some of these patients, do have overlapping psychological problems, and they need to be addressed when they are present. But I don't, personally, my experience in dealing with the patient community is I don't think 83% of them have these overlapping psych problems. I do think a good bit of this is misdiagnosis. And there's some data to support that. Mayo had a 1992 study showing, I mentioned this earlier, that the psychological domains were similar between POTS, congestive heart failure, and COPD, and healthy controls. Vanderbilt in 2009 had a study. It was really interesting. I'll actually talk about it on the next slide. But they showed that POTS patients were slightly less anxious than the general population, had a slight increase in mild depression, which is not surprising if you're dealing with a debilitating chronic illness. In Mayo 2016, this was a study that one of you alluded to earlier. They followed pediatric POTS patients for a period of about 5 years, and they found that the mean mental composite score was normal in the pediatric POTS patients who recovered and who didn't recover. So recovery wasn't based on how well your mental health was doing. But I really do want to emphasize, especially to the patients in the room, if you are feeling that you have a psychological component to your illness or comorbid with your illness, don't be afraid to ask for help. I know myself, because I was told so often beforehand, this is all in your head, I was really resistant when I did get depressed of saying, okay, I need to deal with this, because I didn't want my doctors who were now treating my POTS to say, oh, we knew your POTS was all in your head. So, go to a separate doctor if you have to. Don't tell your cardiologist you're seeing a shrink, just deal with it. It's really important. You have to care for yourself as a whole, not just your physical. So this was Vanderbilt's study. They noted that a lot of studies look at something called the Beck Anxiety Inventory, which is a commonly used tool to evaluate or for research purposes to look at anxiety. And this anxiety inventory looks at physical symptoms like tachycardia and palpitations to make the anxiety diagnosis or to rate the severity of the anxiety. So they looked at the anxiety sensitivity index, which focuses more on the fear and cognitive aspect, the emotional aspects of anxiety. And so you can see the POTS patients were slightly less anxious than the general population and more anxious than the healthy controls, a little more anxious than the ADHD patients, but definitely not nearly as close to as anxious as the panic population. So lack of access to care. After you are diagnosed, great, I have a diagnosis, now what? Well, if you were lucky enough to go to one of the big specialty centers to get diagnosed, it's really hard to get a follow-up because they're just so overwhelmed. There's not enough specialty centers, and there's too many patients. So a lot of these folks, have traveled really far. Almost half of the patients have traveled more than 100 miles from home. And I was one of them. I actually had to, I traveled to Cleveland Clinic, and it was a huge burden on my family to take time off work and take me there. I certainly was in no condition to travel by myself. And a lot of families can't afford this. There's also a large financial impact of POTS where people can't work, or a parent taking care of a child might have to cut back their hours, or one parent has to stay home. So there's already a lot of financial burden. And then having to travel for care is, some people just can't do it. So that's why we think it's so important to have events like this all over the country to try to, find doctors in different cities who are going to take an interest in this. Disbelief. When you're young and you don't have, your teeth aren't falling out and your hair's intact, and, I don't know what a sick person is supposed to look like, because I've seen plenty of beautiful people die from cancer, but these are what patients are told. You're too young and you're too pretty to be this sick. You look fine. I had one doctor tell me, since you can put on makeup and earrings, you must be better. I said, well, maybe I'm just trying to live as normal life as possible, even though I'm not fully better. I guess I'm better than I was. I'm not bedridden. But this is sort of just a silly judgment to make. The younger patients especially, I saw you at the movies last weekend, so you must be faking. And it's really hard for the younger kids to put up with the kind of peer criticism they might get. The older patients, like, you don't care, whatever. POTS, I equated to being on a roller coaster. This week, I was at the International EDS Symposium for a few days in Manhattan. Then I'm here. Tomorrow, I'm at the big POTS walk. Sunday, I am going to crash. And I'm used to it, and it's okay, because I know there'll always be another uphill after that. But most patients, I think we fall into two camps. You find patients who do everything they can to prevent a crash, and they don't really live much of a life. They kind of become hermits. And then you have other patients who are like, okay, I'm comfortable with my symptoms. They are what they are. I'm going to go out and live my life anyways, and I'm going to crash, and it's okay. So try to fall into the latter category if you can, because this isn't going away anytime soon for a lot of patients. So you have to figure out how to still have a good life. Don't judge a book by its cover or a patient by her lipstick. These are all POTS patients. And POTS is very Caucasian predominant and female predominant, but we wanted to include some diversity here. And if you notice, they're all pretty good-looking people. And I did not ask for good-looking POTS patient pictures. I asked people just on the big POTS group that has about, I think we have about 14,000 members. And I just said, hey, does anybody want to lend me their photo to show at this lecture? And these are the people that sort of posted their photos. So we are a good-looking bunch. A lot of people will say POTS is an invisible illness, and I would argue it's not. You just have to know what you're looking for. And these patients, I don't know the exact percentage. I think it's a little more than half. Do you guys know what percentage of patients get the blue legs? No? Okay. Well, someone told me it was half. I think it was somebody at Vanderbilt. When we stand up, a lot of us get this blue discoloration in our legs. Some people seem to have one leg worse than the other. And then this girl standing in the shower, the leg that's the paler white color, she had her leg up on the wall. She was shaving her leg. And then the other leg was down. So you can see the difference between when your leg is upright and when your leg is down. This is not something that's in the medical literature on POTS, and so it may not be a POTS thing, but we hear this question so often on the support groups. Why is my ear turning bright red and hurting and stinging so bad? So a couple of the patients we started looking on PubMed for like articles about red fleshy ears, and we found this thing called red ear syndrome. It's some kind of autonomic blood flow issue. And so some of the patients get it with a migraine, but this is my photo with the glasses on this side, and I get it, no migraine associated with it. It just happens, and it burns like the worst sunburn ever. Ear gets all red and flushed, and it just goes away on its own. It's probably harmless. Flushing, lots of flushing. These patients, quite a few of them have mast cell related issues. I don't know if the POTS is causing the mast cell or the mast cell is causing the POTS, but either way, we see this in quite a few patients. And sometimes they don't have it for years and then suddenly they start to develop it. So this is one area where we'd really like to see more research, because if you have this mast cell stuff associated with your POTS, I don't have any data proving it, but I think this is probably one of the most disabling parts, one of the most disabling things that could happen with POTS, because it makes you have difficulty eating, difficulty taking medications, difficulty kind of going out and about. Like I have some of this, not so bad anymore, but I was having a really hard time with people wearing perfume, and it just becomes like kind of takes over your life. So it's not good. So another misconception about POTS is that it's rare. Just so you know, POTS is not rare. It's a very common orthostatic disorder. Dr. Gibbons mentioned 500,000 before. There's some other things in the peer-reviewed literature suggesting possibly a little higher, but these are just rough guesses. We don't really know. We don't have solid epidemiological data, and we want that. But for comparison, about 400,000 Americans have MS and about 1 million have Parkinson's. So POTS is not rare. If we had the awareness, we would be as well known as these other conditions. A recent article from Mayo estimated 1 out of 100 teens. And if you look at the census data, that's just about 500,000 teens. And we know from 2 different surveys that about half of the patients report onset of, not diagnosis, but onset of symptoms, half before age 18 and half over age 18. It was 59% in one study and I think 48% here, 48% in the other. So the peak age of onset in this cohort, which was just about 700 patients, was age 13 and 14. The people who said they got it at 1 were people who said they were born with it. I don't know that you can be born with POTS since it's orthostatic, and when you're born, you're probably not standing. But I think the patients that responded with that answer probably have just sort of kind of always had this autonomic stuff, and they, as long as they can remember. This is the study that I think Dr. Gibbons had mentioned earlier, pediatric POTS, Adolescent Outcomes. And it was all the patients they had seen between 2003 and 2010, and they sent out a survey, and 172 patients responded. They had been there, they had been diagnosed about 5.5 years earlier. They were 21 average at the time of the survey. And their mean physical composite score, including the recovered patients, was significantly lower than the norm, 36 versus 50. Their mean mental composite score was essentially the norm. 86% reported improved symptoms, which is really important to remember. If you're a young person diagnosed with POTS, chances are you are going to see an improvement over time. I think it's, sorry, need some water. I think it's probably too early to say, why that is. Is it that you're coping better? Is it that your treatments are working? Is it that your autonomic nervous system is changing as you grow, because these are young patients? Is it that whatever disease process you might have had going on is just resolving on its own, or a combination of all of these, or something else we haven't thought of yet? And the patients who had persistent symptoms did have more physical symptoms than mental health concerns. This is a pie chart from their study. It was just, I adapted it a little bit to pull out the 19.2% of the patients reported that their symptoms were completely resolved. And then another percent reported that their symptoms were persistent but better. This is the first time we've seen the term remitting relapsing used in the POTS literature, which we were kind of excited about because the patients use this term all the time, which is sort of borrowed from MS. Obviously a different disease, but the concept is, it comes and goes. Some of the patients reported that the severity was the same, and then 3.5% reported that it was worse. I wanted to add, in the 19.2%, I actually spoke with Dr. Fisher, who led this. And some of the 19.2% who reported that their symptoms had completely resolved were actually still on high salt, high fluid, beta blockers, and whatnot. So I think that this particular survey is more about, how well are you functioning? What's your mindset about your illness and your health? Because if you're still on a beta blocker, your symptoms haven't completely resolved, you're still treating them. But the important thing is that 86% of patients did report that their symptoms had improved over time. This is just a little tree. We usually use this when we're educating patients. The symptoms of POTS there are many, like many leaves on a tree. And the trunk is spots. And the root causes is something, it's what patients always want to ask their doctors about. Like, what's causing this? And this is probably very frustrating for doctors because we don't know what's causing it. There are a lot of different things that have been found to be causing or contributing to POTS symptoms, whether it's environmental factors like triggers. Common triggers for these patients include concussions. Post-viral would be the most common. In the Big POTS survey, we found about 10% of patients reporting a concussion prior to the onset of their POTS symptoms. Pregnancy, surgeries, car accidents. Genetic causes, I think you had mentioned a few earlier, the norepinephrine transporter genetic issues. EDS, which is probably genetic, we don't have a gene for it. Some patients report mitochondrial dysfunction or mitochondrial diagnoses. We put immunogenetics. I don't think anyone's actually studied this in POTS yet, but we have a researcher out in California who works at a big, famous pharmaceutical company, and he's an immunogeneticist, and he's offered to do some free POTS research for us. So we connected him with one of the POTS experts, and he's going to be doing some of that kind of research. Let's see. This is just a little thing I put in at the end. A lot of doctors, I think they probably teach you this in medical school, when you hear hoofbeats, think of horses, not zebras. So not every horse is textbook. Be on the lookout for a horse of a different color, like the horse from The Wizard of Oz. It's like my favorite movie, so I had to sneak it in here. And even though POTS is not rare, I did have a lot of doctors tell me, you're a zebra. I'm like, well, I'm not a zebra. You just don't know that we're out there. But 1 out of 10 Americans has a rare disease. So you're going to see a lot of zebras. And obviously, look for horses first. But if you don't find a horse, don't give up and tell your patient they're crazy. Look for zebra. So, all right, that's it. Thank you very much.